All right. Welcome. All right. I'm Rita. You are first. Thank you. And and I will pass the slides on. Just say yes.
Okay. We can thank you again, Dr. Stiff, for the invitation to present to the group for an update on SWOG S1803, otherwise known as the dramatic study. I'm presenting this on behalf of the protocol team and specifically also my protocol co-chair, Dr. Parameswaran, who's in India at the moment, so he's unable to attend because I think it's probably the middle of the night there. So next slide. So just to remind people, the basis of this study was to see how we can improve upon the standard of care, maintenance therapy in myeloma, the standard of care being lenalidomide maintenance, which is the only FDA drug approved for maintenance, and it's approved until disease progression. We've had a lot of data with the use of the monoclonal antibody daratumumab in relapsed myeloma and newly diagnosed myeloma, but as of right now, daratumumab is not approved for maintenance, but certainly is under study. The Cassiopeia trial is a trial using daratumumab induction, maintenance, and then daratumumab versus observation as the maintenance strategy, but that really does not reflect the United States, where we rarely just do observation after transplant. So this dramatic trial is really much more reflective of the US practice and also trying to answer a very important question in this time of costs, toxicity, and quality of life as well, which is, do we need to keep patients on maintenance indefinitely? The next slide. So we, again, US population, we have obviously patients that we transplant up to an older age in Europe. So this trial goes up to age 75. I do want to emphasize that because some of the other transplant trials are up to 70. So that, we do have a little broader window. We also reflected that the practice in the US is changing and that there will be patients who get daratumumab as part of induction. So that is allowed as long as they don't progress on their induction regimen. I'll get into a little bit of the changes that we made for COVID, one of them being that in terms of the window to allow enrollment in the study from start of induction. And we've also allowed patients to be enrolled before or after the stem cell transplant. And I'll get into another COVID thing that we in fact also made an allowance to allow patients to have lenalidomide maintenance for a period after the transplant before enrollment. Next slide. So here's the schema again for everyone to remember. Again, register before or after transplant, randomized to either lenalidomide or len-dara for 2 years. At 1 year, patients have a voluntary MRD assessment by bone marrow. At 2 years, it's a mandatory study-directed MRD assessment. And that MRD then will be a second randomization. If you're MRD negative, you will be randomized to stopping maintenance on whatever arm you're on or continuing maintenance. And then again, followed until progressive disease. There's further MRD assessment at year 4. The primary objective is overall survival, which is in part the reason that obviously this is a long study and a large study. But again, one of the biggest issues is no one wants to wait that long for the readout because overall survival has been long, so that we are going to have an early reporting of MRD once all the patients have been accrued and reached that 2-year time point. Let's see here. That's pretty small. I could, perfect, thank you. So as I said, we're gonna, that 24-month. Now here's the biggest challenge. And again, I thank everyone from the transplant centers around the country in terms of the challenges that we faced last year with COVID. One of them being the Myeloma Society recommendations and ASTCT recommendations in regards to frontline transplant being postponed for myeloma. And indeed, I can only speak to our center, but many other ones, we stopped doing myeloma transplants for at least 3 months. And so, that clearly had impacts in regards to this trial. So next slide. So what we did is that we submitted a COVID amendment that we extended the window from induction. It used to be 12 months from induction to transplant. We extended that to 18 months, realizing many patients had transplant delayed. We also extended the window that patients could start maintenance because many patients didn't want to start maintenance, especially with daratumumab because of the COVID concerns. So we extended that from 180 days to 270 days. And we also allowed patients to get 6 months of lenalidomide maintenance off protocol before registering to the study. In addition, we've allowed up to 2 months delay of daratumumab because many patients were not coming back to the center because of COVID for many weeks to months. So we made those adjustments. We have, that was a temporary amendment. We submitted a new COVID memo that we just heard yesterday. I think Dr. Stiff was on that call too from Dr. Little, was approved, extending this amendment till the end of this year so that these things will remain in force. And I think that's an important one, especially the 18 months. We get a lot of questions about that. Next slide. So I'm very happy to say that accrual, even with these COVID challenges, accrual is been above projections. And in fact, that 430 is 445. We've enrolled about 21 patients in the last 30 days. We're a third of the way accrued already. So we're very excited. We received news last week that Canada is going to be activated hopefully by the second quarter. So that will also increase our accrual and hopefully even further, be above our projection. So that is great news. And again, I thank everyone on this call for their support of this study. Now, as I mentioned, MRD is a huge part of this study. And so clearly when you're doing this larger trial, also in terms of samples, compliance, as well as success rate in this. And so this is just a list of samples that we've received so far, and that we've run 275 samples. We've been successful in finding the clonal sequence in 88% of those samples. So that is actually quite good. And just to give you some context, in the IFM Dana-Farber trial, they had about a 20% failure rate. So we are doing quite well, and a little bit even better than we had projected. So, that's very encouraging. Just to remind centers, these results are blinded. So centers have been calling and saying, oh, I didn't get the MRD results. They won't be until the study has accrued. Again, just to remind you, this is the COVID memo. And again, we have an updated COVID memo that you can refer to in regards to accrual and eligibility criteria. Next slide.
That's it.
Oh, that's it. So thank you again. Thank you, Dr. Stiff, for the opportunity to present.
Okay, so a couple questions that came up, which we addressed a little bit yesterday, but I get a lot of questions about why can't, especially patients on a lenalidomide arm, get their follow-ups and treatment with local physicians, and ditto for the daratumumab, since the subcutaneous injection is now FDA approved.
So for patients on lenalidomide, there is, as part of that COVID memo and amendment, some flexibility in terms of how often they have to return to the center, so that they can get local labs monthly and come back every 3 months. And it's sort of similar to what we did with the BMT-CT and Stamina trial. So for the lenalidomide arm, there is a little bit more flexibility because that is commercial lenalidomide as well.
Okay. Why do they need labs every month for people on long-term maintenance with Revlimid? We don't do that as routine care.
We do it as routine care. So I guess that's why we built that into the study. I guess it's just different center of practice. And that's what we did in Stamina. So a lot of this trial was sort of built upon Stamina, really. And that worked well with the every 3 month back to the center and monthly labs.
And then the DARA.
So the DARA is a little bit more complicated because this is being provided, and it's investigational supply of DARA. So it's not commercial DARA that's being used. So that's the first part of it. So part of the drug distribution of this drug is through investigational supply. as you know from the call yesterday, and we did have a meeting with Janssen to specifically ask and address this, they will allow sites that have satellite centers, that would be an option as long as the main site is comfortable with the satellite center in terms of they having adequate resources for toxicity monitoring, data collection, and a way of drug distribution to that site. So that is sort of the one option we can offer is, again, satellite centers from many of the institutions as an option if you're already working with them in terms of your investigational trials there.
All right, so that can happen now, or do we have to wait for an amendment?
No amendment. They really said that is up to each individual site and their own IRB in regards to if the satellite can follow. Those investigators would need to be added to the 1572 if they're not already. Again, I think each center handles their title pages differently, right? And who they put on the protocol, etc.
Okay. All right, thank you. Since we're behind, we'll just keep moving. The next is the Alliance 051301 trial, which I'm going to present very briefly here. This is also endorsed by and being done with BMT CTN is 1201. This is the ibrutinib or no consolidation for ABC type DLBCL. Bavis Andreas is the PI. So this is again a randomized trial for salvage auto transplants for ABC DLBCL. And samples are sent to Cleveland Clinic. There's about a 1 week turnaround time for analysis of these samples. You can send unstained slides or stained slides with the appropriate immunophenotyping analyses, and you're going to return back results within a week. And again, we're using immunocytochemistry and no longer the PCR technology. Patients are randomized to either CBV or BEAM plus or minus ibrutinib during the PrEP regimen, and then once engraftment is achieved for 12 monthly cycles, or placebo. So it's a placebo controlled trial. Here's the update as of March 21. There was an amendment August of 2019 that permitted the use of immunocytochemistry, not PCRs. 80 patients have been registered since then. Of these, 47 have actually gone on to transplant, and that's compared to the 229 pre-Amendment 6 and only 28, or a little bit more than 10%. So we're running more than 50% of patients who are registered or who are pre-screened are getting onto the trial. So we're a little bit encouraged there. However, the accruals are lagging a little bit. We did take a bit of a hit for COVID initially, and then a big spike up after centers started doing transplants again, but it's kind of faded over the last few months. So we'd really like to get this trial done. We estimate that approximately 5 to 6 patients need to be registered on this trial per month to meet the accrual goals within the next 3 years. We are starting to send around monthly notices of accrual updates. We hope that, again, centers will consider opening this or reopening this, especially since the CAR T comparison trials are pretty much done now. So 25%, including those prior to the Amendment 6, have been entered onto the trial and randomized. We need 6 randomized patients per month to complete the study enrollment in 3 years. Even with a 25% drop from pre-registered time, that means 8 patients need to be registered monthly. Again, it only takes 5 days to get your slides reviewed at Cleveland Clinic. And Alliance is re-looking at the statistics to see if trial enrollment can be lowered. And there's several things that they're going to propose over the next month or so to CTEP to see if we can lower the total number so we can get an answer a little bit quicker. But this is, again, a critical trial. We've done these trials before, and again, it's a lot simpler to get patients on as compared to previously. So with that, let's talk about the ECOG A4151, the rituximab with or without stem cell transplant in patients with MRD negative mantle cell lymphoma in first complete remission. Hopefully Brian Till is on and will update us.
I'm on. Thanks, Dr. Stiff. Yeah, so this is to see if they're among MRD negative complete remission patients, whether they can be spared an autologous stem cell transplant in frontline mantle cell lymphoma. You can move to the next slide, please. So here's the schema. Patients can receive any induction therapy, so we're trying to kind of mirror kind of a real world situation here. During or after induction, they can, you have to submit their baseline tumor tissue to Adaptive for the clonoSEQ ID test to identify a clone. They then get restaged with a PET scan and bone marrow biopsy. If they have a clonal marker identified, which has been the case in more than 99% of patients, so it's very reliable, they then get and they have at least a PR, then they get their blood sent to Adaptive for the detection of minimal residual disease. If they're in a CR and they're MRD negative, that's the population of interest that gets randomized, and they get stratified by MIPI-C score and high-dose Ara-C versus non-high-dose Ara-C induction. And you can't see there, but there's a they're randomized to transplant or no transplant, and then both arms get rituximab maintenance for 3 years. Everybody else who doesn't get a MRD negative complete remission stays on the study, and if they have a MRD positive or partial remission, or they're MRD indeterminate, they stay on the study and get an auto transplant and rituximab maintenance for 3 years. Next slide, please. So accrual is moving along. We're targeting 434 randomized patients, and we are more than halfway to that goal. 353 patients have assigned to the treatment arm. That's not all randomized, but about more than 75% of those patients are MRD negative CR. So the majority are randomized, and that was a little bit higher than our projected values, as was the success rate of the clonal identification test. ECOG is not surprisingly leading the accrual. SWOG is lagging behind a little bit. I show the leading sites there in the box, with Kansas, City of Hope, and Seattle being the leading sites for SWOG so far. Next slide, please. So the not a lot of updates, but in terms of the COVID-19, I think some of the treating physicians were inquiring about whether they could miss rituximab maintenance doses to either mitigate the risk of COVID-19 or to try to optimize vaccine responses. So after some deliberation, the study team, we decided to allow up to 4 doses of maintenance rituximab to be held, and kind of you have to tack them back on at the end and make them up. So I think there's some, I personally am not sure about how effective that strategy is going to be in terms of vaccine responses. The data just came out this week, many of you may have seen, from the Israeli group in Blood, showing that patients who had rituximab, at least in the setting of CLL, patients who have had CD20 antibodies within the last 12 months had a 0% serological response to the COVID-19 vaccine. So I'm not sure holding 4 doses is going to get the job done, but you can do it if you want to. So then a couple other reminders. We are trying to remind people to let the white blood cell count recover after the last cycle before you send the MRD test, just because it improves the chances of having a high enough denominator. You need to have at least 100,000 genomes to be considered valuable, or else it's MRD indeterminate. You can, if you're trying to streamline things, let's say they finished induction and you want to try to get them to transplant quickly, you can submit the tumor tissue and the peripheral blood sample at the same time to kind of streamline the process, and Adaptive will hold on to the MRD test and run it as soon as the clonality test is done. You don't have to wait for the results of the clonality test to come back. And then finally, there have been some patients who have refused their treatment, their assigned treatment arm. And just to make sure you're aware, if that happens, they don't come off study, so they're still on study, and you still follow them for survival, and then we can do a separate, intent to treat versus an as treated analysis later. So we continue to collect data on them. So that's all I have, and I'm happy to take any questions, and thank you for supporting the study.
Okay, so again, you can put your questions in the chat. Unfortunately, because I'm doing the slides, I can't see that. And if I try to see it, which I did already once, the screen doesn't work. So we'll come back to it in a bit. So next we have several pending trials. The first one is the randomized phase 3 trial of Bumel Velcade versus Mel for second autograft for multiple myeloma with isatuximab maintenance. And Patrick Hagan hopefully is online now and is going to present this one.
All right, sorry, I was just muted. Give me 2 seconds and I'll bring it up. Okay, there we go. There we go. Okay, so this is a, excuse me, this is a study that has been in development for a while now and is recently actually presented at the NCI Steering Committee. So we'll go through the background real quick here, but this is essentially salvage second transplant study comparing an intensified prep regimen of busulfan with melphalan and Velcade as composed to our standard melphalan in patients who have a long remission duration after their first transplant. And the objectives here of the study is to compare, again, the intensified high-dose regimen with the standard melphalan with the goal of achieving a 12-month improvement in median PFS. We can go to the next slide. So importantly, despite advances in CAR-T and lions and tigers and bears and many new myeloma therapies, and even some, I think, recent publications showing a decreased utilization of stem cells after first transplant, and we're still doing consistently 600 to 700 second transplants annually in the U.S. And in terms of the inclusion criteria for this study, many of these are long remissions, as you'll see here, kind of on the far right column. About 80% of those who get a second transplant go more than 36 months before they relapse. So this is I think, a prime patient population to look at the value of second transplants in, and based on the data, these are the patients that get the most benefit. So I think we're treating appropriately nationally, actually. And then importantly, in the upfront setting, there's now our phase 2 data shown here at the bottom, where we compare to a historical CIV-MTR cohort, as well as the MD Anderson actually randomized phase 3 data, comparing a Bumel-based prep regimen to standard melphalan, both of which showed pretty impressive advantages to the Bumel, particularly the phase 3 data, about a 20-month PFS advantage, which again is on par with what we might expect with maintenance versus no maintenance, or even upfront versus delayed transplant in the upfront setting. So we can go to the next slide. So we really think that this is a prime opportunity to look at this regimen. We utilize the bortezomib in the prep regimen at day -1 based on preclinical, but also clinical data. And we think, again, that these patients in the salvage setting, particularly the long remission, those who achieve these long remissions are ideal to evaluate with this prep regimen. We felt really strongly as the study developed that there needs to be a uniform maintenance post-transplant, and after kind of a few changes actually over the last 2 years, ultimately it was decided that isatuximab would be an ideal choice because many patients will have received DARA, and we'll go over the details of that in a second. It has a favorable toxicity profile, and importantly, we have full support from Sanofi for study as well as correlatives, et cetera. We can go to the next slide. So here's our eligibility criteria. So importantly, in terms of inclusion, patients must have gone at least 18 months from their first transplant to be eligible. They do have to be eligible for a second transplant based on the local institutional guidelines, and an ablative second transplant at that. So these are not patients you'd be considering for a MEL 140, for example. They have to have some measurable disease, but they can be non-secretary and extramedullary only, although particularly extramedullary will make up obviously a very small fraction of these patients. They can get any induction or salvage regimen after they relapse after their first transplant, and as long as they can achieve a partial remission, partial response at time of referral, they would be eligible. They can get 1 to 2 lines of therapy following their first relapse, so no more than 3 total lines of therapy, with their induction, transplant, and maintenance considered 1 line. They can be previously treated with or progressed while on DARA, but they cannot be refractory to DARA. So for example, patients can be on the SWOG maintenance study and ultimately progress even if they're on the DARA arm. And again, as long as they're able to achieve a PR with their reinduction, they'll be eligible. And they have to have a minimum stem cell available for transplant, either stored or we would allow remobilization, although that should be rare. Some important inclusion criteria for the study are age, due to some concern for potential toxicity, but there are very few second transplants being done in this age bracket anyways. You can't have had a previous tandem or an allo transplant. You can't be refractory to any of the investigational agents, and current amyloid, and then some kind of standard organ criteria listed here. Go to the next slide. So here's the treatment schema for the study. So again, eligible per institutional guidelines, at least a partial response to reinduction. It's randomized in a 1-to-1 ratio to either the intensified regimen versus the MEL 200, stratified by disease remission duration, either 18 to 36 or greater than 36 months, RISS stage, and then again with repeated data showing response pre-second transplant really is important, stratified by response, either CR less than CR or CR greater. The treatment arms are listed here. Importantly, the busulfan is dosed pharmacokinetically with 2 doses given on days -6 and 5, and then PK adjusted doses for the final 2, melphalan 140, and then again the bortezomib on day -1. And then all patients will go on isatuximab maintenance, and then the outcomes as listed here, with the primary being PFS, and then some important secondary outcomes including quality of life, MRD, etc. Next slide. So here's the statistics, but kind of importantly in terms of the assumptions, this is the median PFS as the primary outcome, and really based on the recent published CARFI data out of Europe, that we would expect the standard MEL arm to have about a 24-month PFS. We're looking to see about at least a 12-month or a year advantage for the intensified approach. We think we would need about 62 patients a year for a total of 250 eligible patients. That's about 10% of the second transplants, and remember, just as a note, over 80% of those are long responders after their first transplant, so we should have a good eligible patient population, and we would have an 80% power again to detect that 1-year PFS advantage. Go to the next slide. We can skip this one. Next slide. And then finally, like I said, we do have full support from Sanofi to look for drugs correlatives and then costs. They remain engaged and supportive of the study, and as I said, it's been approved by SWOG at this point, and continuing to develop the study as we move forward. So I think that's all I had for this study.
So where does it stand vis-a-vis SWOG and NCI and BMT-CTN?
So it was presented at NCI on this Monday. Actually, we're waiting to hear what the vote is in terms of support. The BMT-CTN remains very interested. It's been presented actually a couple times at that meeting. So in terms of whether or not they will formally support or co-sponsor the study, that is a little bit yet to be determined, but there remains support for the study. And we should kind of have some more information on that really in the coming weeks here, to be honest. And then in SWOG, we're just working on budgeting and moving the study forward, protocol, etc.
And a lot of people are now treating patients with quad therapy or DARA induction regimens. Somebody who's had prior DARA, they are eligible as long as they are not progressing.
So yes, exactly. So they can't be, well, you have to be in a partial response before you head to the second transplant. So you can't be actively progressing on DARA or any agent coming into transplant. And you can have progressed previously. So if you got, if you relapse and you got a DARA-based regimen, you went along for a while, you progress, you switch therapy to a different regimen, maintain a response, you would then be eligible at that time. But you can't be refractory to daratumumab, meaning you can't have had DARA and never responded, or a CD38, ISA, etc. previously.
Okay, so let's keep moving. The next is the randomized phase 2 consolidation proposal for patients in an incomplete remission following commercial CAR T therapy. We have Brian Hess and Nesh Hussain that are going to present this proposal. It was presented at the State of the Science Symposium and was the leading lymphoma proposal. and got a lot of support during that meeting to move it forward. And again, SWOG is in the process of doing just that. So who's up? Brian
It's
or
Nash.
Nash? Okay, go ahead.
Yeah, so thank you, Dr. Stiff, for the invitation to present this concept. So these are kind of some of the members of the committee, and then to everybody else, just a quick update. We had some changes we had to make to the overall concept that were made after the slides were submitted, so I'll kind of talk through those at the appropriate points of the presentation. Next slide, please. A little bit of our agenda would be to go over the background, objectives, go over the schema, kind of the exclusion criteria, and our endpoints. Next slide. So what we know is that based on looking at the real world data as well as what's been done in the clinical trial setting, the overall response rates to the CD19 CAR T cells and complete remission rates have ranged anywhere from 50 to 80% for overall response and 40 to 60% for CR rates. However, despite initial really promising responses up front, a lot of patients will eventually relapse. And these relapse patients seem to have very minimal response to other lymphoma therapies, and the prognosis remains very poor regarded. What we do see with the ongoing follow-up of patients more in the long-term setting is that, patients who achieve a CR early on seem to have the best response. And what we've also seen is that 65 to 70% of patients in a PR and 90 to 95% of patients with a stable disease at day 30 after CAR T infusion will progress, usually before day 120. And so this represents really a patient cohort with an unmet need and forms a basis for this proposal. Next slide, please. This is a quick kind of like a summarization of the clinical trial and real world experience to date, kind of pretty much highlighting the fact, even though the overall response rates are very very promising at the 50 to 80% range with a nice CR rate, what we do realize is a large portion of these patients, especially those who don't achieve a CR right off the bat, will eventually relapse, usually within the first couple of months afterwards. And I think many of us have been in that situation where we have a patient with a PR or a stable disease, and we have to kind of make a decision at that 1 month PET scan what to do next. Kind of wait and watch it, try to do something else to try to consolidate the response. Next slide, please. Can we get advance to the next slide, the animation, please? Okay, so very much this kind of summarizes kind of the more nitty gritty, but what we want to highlight would be that, when we look at both the clinical trials and the real world experience, 54% of patients in a PR did eventually convert to a CR in the Juliet trial. When we look at, the Zuma-1 trial, about 38% of patients converted to CR after day 30 imaging assessment. And when we looked at the Lysocell trial, 56% of PR patients converted to a CR, and about 21% of patients converted from a stable disease to a PR or a CR. Now, when we look at the real world data from two different groups looking at Axicell, 32% of patients with a PR at day 30 improved to CR by day 90, and 7% of stable disease went from day 30 went to a CR by day 90. With a different group kind of looking at Axicell, in their case, the 32% of patients with a PR at day 30 improved to a CR, and they just noted that 2% of their patients were in stable disease but didn't really report on their kind of further outcomes. Next slide, please. And then this was initially presented as a ASCO abstract by the Stanford group, and more says it was a letter to the editor in Blood, which looked at outcomes after Axicell relapse. And the thing to highlight really here is that it doesn't really have even whether you do radiation, chemotherapy-based approaches, even IMiD-based approach or checkpoint inhibitors, there isn't really a great response overall. The responses can be anywhere from 40 to 30%. And so the question would be do we need to kind of work on try to keep patients from relapsing in the first place post-CAR T-cell therapy? Next slide, please. So one thing that's kind of come about as we looked at these patients undergoing CAR T-cell therapy is that perhaps a non-invasive approach to disease assessment as well as to determine response may provide some more information to us as we're looking at which patients may require further intervention versus not. A number of different groups, including the Stanford group, have kind of presented looking at minimal residual disease patients, large B-cell lymphoma patient undergoing CAR T-cell therapy. And what we have seen is that the dynamics of clearance of MRD seems to correlate with patients who have a more sustained response versus those who progress. Next slide, please. And this was initially presented as a ASH abstract and now as a JCO article in Press, which has shown that the MRD status at day 28 seems to have like a correlation with the kind of the overall progression-free survival of these patients, where patients who are deemed to be MRD negative at day 28 seem to have an ongoing, like a pretty nice like progression-free survival as compared to the patients who have MRD positive day 28, who, as you can see here, seem to relapse usually within the first 3 months post CAR T-cell therapy. And so the preliminary MRD data may be kind of used to be able to further extrapolate to, follow these patients long term. And so the objective for this this trial would be to compare the progression-free survival at year 1 for patients with relapsed refractory large B-cell lymphoma or follicular grade 3 who achieve a stable disease or PR at the first imaging assessment around day 30 after commercial CD19 CAR, and who either receive consolidation therapy versus those who do not, are in kind of a control arm. A co-primary endpoint is a translational marker endpoint is to evaluate the association of non-invasive minimal residual disease by using the next-generation sequencing CAPS-seq based on first imaging response after commercial CAR to see how that correlates with progression-free survival. Secondary objectives include looking at overall survival, the CR conversion rate, as well as looking at treatment-related adverse events from those receiving consolidation therapy. And finally, to look at the concordance between total metabolic tumor volume and the rates of complete remission conversion CR up to 1 year in those patients who are randomized to a consolidation arm, as well as those who are in the control arm. Next slide, please. The inclusion criteria briefly is to include all patients who have DLBCL or follicular 3B who are deemed to be eligible to receive a commercial CAR T-cell therapy. Bridging is not allowed, but cannot have any of the study interventions as part of their bridging. However, they are allowed to have had either polatuzumab, mosunetuzumab in the past, but cannot progress with either drug within the last 12 months of receiver each. Key exclusion criteria includes receiving a non-commercial CAR T-cell therapy, or having active CNS disease or CNS disease prior to CAR T infusion, or having Richter's transformation. Next slide, please. Now, this is kind of the original trial schema that we had, which was to have like kind of a first and second registration, with the first registration for patients who are initially being registered prior to getting CAR T-cell therapy, preferably prior to the lymphodepletion, but have been deemed to be eligible for CD19 CAR, and then secondary registration based on those patients who had an imaging response at day 30, or imaging assessment at day 30, looking at their overall response at that point, and then being broken down into either a group that has partial response or stable disease, who are candidates for second registration to be randomized to an intervention versus observation, those who are CR who would be on surveillance for standard of care, or those who have progressive disease who would be treated per the discretion of the treating doctor and not be a candidate for secondary registration. Now, here's where a major change has been made in the last couple of days based on discussion with CTEP, is that initially our thought was to have one intervention arm using a combination of mosunetuzumab and polatuzumab. Based on discussions with the CTEP, we have decided to actually expand this to 3 intervention arms, which would include mosunetuzumab monotherapy, polatuzumab monotherapy, as well as a combination of mosunetuzumab and polatuzumab, and then of course an observation arm, with the plan of the interventions in the intervention arms to be for a duration of 6 months. And this will be accompanied by MRD assessments that will be done at pre-lymphodepletion at day 30, day 100, day 180, and day 365, or at the time of relapse, to be more or less try to correspond with when patients will be getting imaging assessments. And to note, the day 30 imaging will be centrally reviewed by the radiology group. Can we go back one slide, please? Okay. Okay, so okay, we can go forward one more time, please. Sorry. Okay, so this is just going over based on like the initially when we had the treatment arm mosunetuzumab, polatuzumab. The reason for going with this combo is based on the efficacy report from 22 patients who were treated. 12 of them had de novo DLBCL. The overall response rate was 75%, with a CR rate of 58%, and it was dosed in a 21-day cycle with mosunetuzumab like at a 1, 2, 16, 30, and the polatuzumab at 1.8 milligrams per kilogram. That started on cycle 2, day 1, for a total of 6 cycles. And then, the interesting thing of note was that, as far as prior CAR T-cells, 7 of the 15 patients with de novo transferred DLBCL had previously received CAR T-cell therapy. Toxicity-wise, 16% patients had CRS, all grade 1 by AST/CT criteria. There is no eye cancer reported, and other AEs included like such things as neutropenia, pneumonitis, and AFib. Neutropenia was grade 3 in about 11% of patients and grade 4 in 16% of patients, but no febrile neutropenia. And the peripheral neuropathy was seen in about 16% of patients. Now, I'd like to ask everybody to use their imagination at the moment, but kind of a little bit more with the other two drugs. Mosunetuzumab's efficacy was shown in a study of 98 patients. 32 of them had a prior auto transplant, with an overall response of 37%, with a CR rate of 19%, and 30 of these patients had a prior CAR T cell therapy, with their overall response being 39%. With 4 of those patients have gone on to a CR. Toxicity really with mosunetuzumab has included CRS, which was seen in approximately 28.9% of patients. With about 3 of those patients have like grade 3 or more, and neurotoxicity is seen in about 1.1% of patients per ASTCT criteria. With regard to polatuzumab, the efficacy is based on looking at our pola combination in 39 patients treated in the Romulus study, with an overall response rate of 54% and a CR rate of 21%. And with neutropenia being the major toxicity, which was seen in 23% of patients, and peripheral neuropathy being seen in 56% of patients, grade 2 in 26%, and grade 3 in 10%. Next slide, please. So once again, this is kind of based on the previous concept. One of the arms in our current concept will continue to use this mosunetuzumab polatuzumab vedotin combination with the scheduling as seen here, where we see that there's kind of a lead-in with cycle 1 using just mosunetuzumab by itself, followed by cycle 2 where there's mosunetuzumab 60 plus polatuzumab with like a cycle 3 beyond kind of dropping down the mosunetuzumab dose. And then, of course, the biomarkers that we talked about before, which will be kind of done at pre-lymphodepletion day 30, day 100, 180, and about day 365. Now, for the other two arms, with regards to mosunetuzumab, that'll be once again in a 21-day cycle, kind of doing kind of a similar lead up as seen here for cycle 1 in the combo arm, and then from cycle 2 doing the 60, and then cycle 3 to 8 doing the 30 milligram dosing. For polatuzumab, it would be kind of a straight up 21-day cycle using a 1.8 mg per kg dosing schema. Next slide, please. With regards to endpoints and goals, the study needs to be completed with kind of cooperative group setting. As Dr. Stiff mentioned, it's just one of the two proposals from the BMT-CT and Lymphoma Science Symposium that was presented at the BMT and CT and SOSS in March, which was ranked for overall number 1 lymphoma for the proposal overall. If the consolidation therapy appears safe and effective compared to control, this would set up for a phase 3 study with hopefully performing as an MRD CAP-seq adaptive trial. And if consolidation study does not appear safe or effective, this at least gain some more understanding regarding CAP-seq in this setting, and looking at how it might be able to complement some of the imaging assessments that we're doing in these patients. And of course, the big thing to notice, our statistics are kind of being redone based on this adjustment in the overall trial design, but we approximately need about, we project we need about 120 patients in the intervention arms who have like PR, CR, and so it approximate leading a little bit of more than 300 patients total on the trial itself, about 318 give or take, but that number still being finalized at this time.
Okay, I think that the whirlwind trip. So where does this stand now as far as submitting to the executive committee and then to CTEP?
So I think the biggest thing we're doing right now is I think everything pretty much is done other than the statistical planning. We're just kind of going through that one more time. I think Michael LeBlanc and Hungley are kind of working with us on that. So once that is finalized, I think we should be ready to proceed and move forward.
And do we have commitment from Genentech for the use of these two agents?
Yes, we have preliminary buy-in from them and support from them on the use of both of these agents.
Okay, now your co-chair Brian Hess is online. Brian, do you have any additional quick comments?
No, Nash, thanks for presenting. That was great, and we're excited to kind of move forward with this. With the once we have stats reviewed, I actually, kind of like the comments that came from Dr. Freeberg and Rich Little regarding having 3 treatment arms and 1 observation arm, both just to make it, possible for 75% of the patients to be randomized to a treatment arm, and in case there's any, significant toxicity with pola mosun, having it only, 22 patients be treated. I think this is a safer bet, and I'm pretty confident with all the support that we've had from all the other groups that we'll be able to complete this enrollment in a fairly timely fashion.
Great. We do plan to bring this to the BMT CTN for endorsement as well. So hopefully folks will get the all-important credit for their grants. Thank you guys. And again, hopefully by the next meeting, we'll have some finalized version of this, and we'll be looking for getting patients treated on this. Next is concept discussions section, and we're going to talk about two concepts. First, Dr. Hagan's going to come back, talk about amyloidosis, and Rich Mezeros is going to talk about a BOS proposal, something new for us, potentially working with the Leukemia Committee, and I'll make a final comment on the basket trial concept as well. So, Patrick, you want to take it again?
Sure, why not? So beautiful. So this is a concept that's been in development for about a year now, with a lot of help from many listed here in SWOG, as well as a lot of cooperation and work with those folks in ECOG and the BMT CTN. And really, you know, the treatment of amyloid, which hasn't moved a lot in the last 10 to 15 years, really has really moved recently with the Andromeda study and now the upfront approval of DARA-BCD. So we really feel that this is really a key and an opportune time to evaluate the role of high-dose melphalan and autologous transplant amyloid, something that I think the field has struggled with originally due to toxicity and now due to the question of the kind of its ongoing role. So we can go to the next slide. So just in background, so we've only had one randomized study ever evaluating the role of transplant and amyloid, and that compared basically a little bit of melphalan to a lot of melphalan. So it was either non-transplant based melphalan versus high-dose chemo and transplant, published back in 2007, but really outdated and flawed due to really high TRMs, and just a completely different in terms of how we approach patients these days. Because now we know that transplant, if the patient is chosen appropriately, can be very safe in amyloid, obviously still potentially higher TRMs than in myeloma, but in experienced centers in that 2 to 5% range. I just got gray blocked out here. There we go. So making it challenging on me. And so also what we know and the data is really supporting is that induction is becoming the standard of care in amyloid, even in those patients who are heading towards a transplant. And there's been several publications recently that have really shown that bortezomib-based induction and then really the dose of melphalan at transplant is what's predicting outcomes in transplant-eligible patients. We also know that practice patterns are drastically different between Europe and the United States. So in the US, the kind of our best estimate may be about a third of patients with newly diagnosed systemic amyloidosis undergo transplant. There's UK data and some other data out of Europe that in Europe that number is significantly less, maybe down in the 3 to 5% range. And then we also know that although previously challenging, I think our appetite for clinical trials in amyloid is improving. That was shown by the Andromeda study, which was obviously a commercial study, but had a very high enrollment and achieved that prior to the estimated timeline. And then our recently completed SWOG study, actually looking at isatuximab in the relapse setting, accrued very quickly, faster than we had predicted. So I think there is an appetite to investigate this disease. And go to the next slide. Excuse me. So importantly, also, we're still doing transplant amyloid, kind of similar to what I had mentioned previously. For myeloma, really the numbers continue to go up despite the introduction of these new agents. So in terms of feasibility, we think this is important. Next slide. So we would hypothesize the primary outcome of the study is actually looking at something called the modified progression-free survival, which I've defined here on this slide. So this is a unique endpoint that was developed in the Andromeda study, but we think merits further investigation. Partially because this is a rare disease, but also because it really looks at the important endpoints of both hematological progression, but also organ progression in these patients. So we hypothesize that the modified progression-free survival would be superior in patients who would undergo high-dose melphalan auto transplant as consolidation, as opposed to those who would continue with DARA-BCD as their consolidation. And our primary objective on the proposed study would be to look at this endpoint, again, comparing the two arms, we would really have a lot of important secondary objectives listed here, including things like quality of life, obviously survival and treatment-related mortality, organ response, hematological response, and then ultimately hematological progression-free survival. You can go to the next slide. So this is the study schema. So basically enrollment would be based on eligibility, which I'll touch on in a second, but basically transplant eligible. All patients would undergo 2 cycles of Dara-VCD as their induction. And this, we've had a lot of discussions about 2 cycles versus 4 cycles versus 6. I would say we settled on 2 cycles because if you look at the Andromeda study, time to complete response in those who got Dara-VCD was actually only about 2 months. So many patients are already in CR by 2 months with 2 cycles. So following this, if patients were still transplant eligible, they then would be randomized to one of the 2 consolidation arms. One would be to continue an additional 4 cycles of Dara-VCD. The other would go on to high-dose chemotherapy and autologous transplant with melphalan conditioning regimen. And then all patients would complete a total of 2 years of daratumumab. So again, trying to look at this as a uniform approach between the 2 arms in terms of the maintenance. Next slide. So in terms of key inclusion and exclusion criteria, patients have to be transplant candidate at time of diagnosis and at time of stem cell mobilization after 2 cycles of induction. Ultimately, we would leave that up to the enrolling centers, but we would really, we are going to build into the protocol and are going to highly recommend most centers strict to the updated Mayo criteria. They have to achieve at least a partial response to induction therapy. That's going to really exclude very few patients, to be honest, if you look at the overall responses of Dara-VCD. And then in terms of key exclusion, they cannot have symptomatic myeloma, although they would not be excluded purely based on plasma cell involvement in the marrow. And patients who don't, again, achieve at least a partial remission to induction would not be randomized, but they would be followed on a registration basis. And we would predict that to be maybe about 3 to 5%. You can go to the next slide. So our statistical considerations are listed here. So we think it's safe to assume about 250 to 300 transplants are being done annually. If you look at the outcomes and the response rates of Dara-VCD, we're seeing an overall response rate of at least 92%. Again, I mentioned the median time to response is quick with this regimen. So VGPR about 17 days and CR about 60 days. So we should know this by 2 cycles if patients are going to achieve a response. We were estimating about 5 to 10% of patients will not be randomized due to a lack of response, and about a similar proportion potentially due to toxicity. And this is one of the challenges of the trials, to try to figure out patients will be lost to attrition, which can range from as low as 5% in amyloid trials to as high as 20 or 30%. But right now our modeling is looking at about 10 to 15% dropout for lack of response or toxicity. Go to the next slide. So again, our primary endpoint is a modified progression-free survival in the auto transplant arm as opposed to the non-auto transplant arm. Our statistics are listed here. I won't go through the details, but it's pretty standard. Right now we have it modeled as for an 83% power and a 1-sided type error of 0.025. We're actually going to change this to a 2-sided type error after recent discussion, so the slide is not 100% updated. But we would need 150 events of full information to be able to generate this power for a hazard ratio of 0.65 in favor of the high-dose melphalan arm. Again, this would mean we would need to enroll about 230 patients in total at randomization and randomize in a 1-to-1 ratio. Again, for a dropout, we would inflate that to about 253 patients. So we're looking at about 10 patients per month over about 25 months. Interestingly, we did send out actually recently a DMT CTN myeloma intergroup survey following the recent meeting, and there is actually a lot of interest in this concept and really no red flags in terms of feasibility and eligibility and enrollment. Some questions regarding number of induction cycles certainly came up, and also some of the logistics of the maintenance approach post-transplant for those who come far for their transplant for amyloid. But basically good feedback and nothing that we felt would be prohibitive by any means. So next slide.
That's it.
That's it. Okay. So
where's the stand?
Essentially right now where the study stands is we just kind of hammered out some final inclusion exclusion criteria that I just went over. We're waiting on the updated statistics really, and then we plan to present this formally as a capsule for submission to the myeloma working group, hopefully within the next couple of weeks.
Okay, and this is another trial potentially because the myeloma intergroup is basically NCTN and BMT-CTN that we would also submit there as well and get them involved at the protocol writing level. So thank you. Actually, there was a lot of interest from a variety of centers and groups over the last year or so. Patrick had been working on this actually for a year or two before that. I can remember the first presentation and the SWOG meeting, and it was you were kind of hooted down a little bit, but you stuck with it and is taking the lead with again ECOG Alliance and potentially down the BMT-CTN. So thank you and keep going. Now, the next is something new and different, and we thought we would just kind of present this and hopefully get some feedback. Not the ideal way to do that in this online meeting, but as part of the SSOS, Dr. Maziers was in charge of one of the committees and of transplant complications. And a BOS proposal was submitted and was highly thought of. As everybody knows, the BMT-CTN is a grant-funded organization. The current grant is a 7-year grant. Money is spent and overspent, and there's a limited number of trials that can be done through the BMT-CTN. So a lot of ideas, a lot of novel therapies out there. For those that didn't notice, yesterday online, the ROC2 phase 2 study was published in Journal of Clinical Oncology, and I'll refer you to that. It's a novel compound with a 2/3 response rate in patients with far advanced disease, and we think that there might be some opportunities to work on complications with the other committees in SWOG. So I've asked Richard to kind of give us an update and where we think we might be able to go with this, potentially working with the Leukemia Committee. Rich, I hope you're on.
I'm on.
Great.
So this is I'm just going to give a summary of the presentation we gave at the BMT-CTN. So I was asked to chair the BMT-CTN State of the Science Comorbidity and Regimen-Related Toxicity. Next slide is conflict of interest. I think it's, that's irrelevant to this presentation. Next slide. But the goal, we had multiple proposals that came forth, that we thought were felt within a group of 14 of us from around the country. But what was selected by the CTN committee as the executive committee as the top priority of three proposals was the goal that maybe it's a call to action. It's time not to just observe, but actually to act on the ability to see whether or not we can limit transplant-associated chronic pulmonary toxicity. With the hypothesis that if we actually commit to longitudinal monitoring of pulmonary function studies, we're going to define an at-risk patients for early intervention rather than wait to the point that there's such advanced disease that the patients are basically destined to a poor outcome. Next slide. So, this is just a brief comment for all of you. Yes, we know there's infection. We know there's IPS and diffuse alveolar hemorrhage occurs early, but a lot of patients either after infection or after IPS have a restrictive lung disease that impacts their outcome, particularly prominent in children who are growing at the time. But we have this late entity of bronchiolitis obliterans that has become, a plague to all of us. Literally last week at OHSU, a patient at 3 months just presented with first onset BOS. So it does occur early. Usually it comes later in the course of disease. Next. Yeah, so the background is that chronic lung injury, including both restrictive lung disease and BOS, is a major contributor to late morbidity and mortality. It turns out that if you actually look at this, BOS is seen in 5% of patients who undergo allogeneic transplantation. And we know there's a lack of effective screening strategies because diagnosis is usually made late. There's a very strict criteria based on the NIH chronic GVHD consensus criteria for BOS, and thus when the median FEV1 when BOS is diagnosed is 40 to 50% of what's predicted. We have no ongoing defined biomarkers of who will develop it, and we have no measures to figure out how long someone's going to survive. We do believe that more frequent intervention or frequent monitoring may lead to early intervention. And this, by the way, is a theme of the GVHD, chronic GVHD proposal, which is that we need to begin to look early to find signals that preemptive intervention may be valuable and may change the natural history of disease. We all recognize that chronic GVHD is the reason that a lot of people do not get referred to transplant or choose not to go to transplant because of the fear of that their quality of life long-term will be impaired. Next slide. So there have been multiple bronchiolitis obliterans trials, BOS trials. Many of them, there's only been 3 prospective trials. There's only been 1 randomized trial, but I'd bring attention, they're all small numbers, small observations. And as far as most of it being retrospective studies. Next slide. So this is a study from Michigan's group, University of Michigan with Greg Yannick, where they went back and they've analyzed their data for patients. And what they showed is if you identify a patient with bronchiolitis obliterans before they have a significant FEV1 loss, it is really predictive of overall survival. And again, remember that most patients are diagnosed in that 40 to 50% range, and you could see that most patients are doomed to a limited overall survival with that late detection. Next slide. So we've built in a proposal for an early observational trial, which we will do a longitudinal study to actually identify measure parameters and of a lung function, as well as look at potentially collect biomarkers. But one of the key aspects here is we want to develop an early intervention trial, and we're proposing a randomized open label trial for patients with BOS 0P. Next slide. So the interventional trial is the design is that at day 100 is when we'll register patients. Many transplant studies register patients pre-transplant. Well, we know we're going to lose, potentially 10, 15, 20% of patients in that early first 100 days, either due to toxicity or early relapse. So we want to at least eliminate that risk, and we want to basically say, let's register with them when they're at risk for developing bronchiolitis. So we start at day 100. The proposal is to collect pulmonary function studies not once a year, but every 3 months, and then every 6 months in year 2, and then once a year thereafter. And if there's coincident chronic GVHD, though, in years 2 and 3, we'll go back to every 3 months. For the longitudinal trial, again, as we're looking at to determine the natural history of chronic lung injury, but for the BO intervention trial, we're going to use BOS stage 0P. Next slide. Now, what is that? It's an early marker of bronchiolitis. It's actually used frequently in the lung transplant literature, and the lung transplanters follow this. This is a stage. This is stage 0P. It is a spirometry-based parameter, and it defines patients at high risk. And it's defined as someone with a greater 10% or greater decline of FEV1, or potentially more sensitive, a greater than 25% decline in the FEF 25/75. You don't meet overall criteria, the BOS. It's seen in 19% of all allotransplants, and if we enroll patients at day 100, we think that we'll be able to increase that likelihood of finding it in the 20 to 25% range. Median onset is 9 months after transplant, and 40% of patients, who, especially if they have concurrent chronic GVHD, will progress. Next slide. So the intervention trial, again, we register everyone at day 100. We're going to collect data just on lung function. But the moment we see a diagnosis of BOS, stage 0P, they would then be enrolled on the intervention aspect. Right now, our proposal is to using the only drug that's been shown in BOS to have a benefit is right now is steroids, inhaled steroids. It's in the study by Ann Bergeron about 5 years ago, basically showed that it didn't improve BOS, but it stabilized the disease. You didn't have progressive BOS. So we propose a randomized study of inhaled steroids versus inhaled steroids with a second agent, with the 12-month planned therapy intervention, with the goal of a reduction of BOS from 40% predicted from steroid only and from the BOS stage 0P to natural progression to BOS to the fact that we'll be able to cut it down to 20%. Next slide. The study synopsis, just is what we thought was there's various candidate second agents. We have talked to the company that that Pat's just referred to that makes the ROC1 inhibitor. We've also talked to company that makes ruxolitinib, which has another drug that it shows excellent data in the phase 3 in chronic graft versus host disease. Industry partners are interested. We think it will take a sample size of 182 patients, 91 per arm, to ultimately show that 50% reduction, or basically the 100% reduction, having the risk of VOS, and going from 40, from dropping it from 40 to 20%. Next slide. And so in the observational study, we could potentially look for 800 subjects. Again, this is a proposal through the BMT-CTN also, or we could actually focus on the preemptive study where we, once we have identified a patient with decline in pulmonary functions, that we could then enroll them and hopefully intervene to prevent the progression to life-threatening and debilitating bronchiolitis. And I think the last slide coming up is, so the summary was from outside. It was considered it was the highest priority of our committee. It was the third highest rank. It was in the top 3 for non-malignant studies, and it was felt to be very feasible, and doable, and something that should be considered. And I think one of the there's a lot more we could talk about it, but just one of the discussions that Dr. Stiff and I have had is that this, again, is what he alluded to. This is a proposal of the CTN. It may, if it is approved by CTN, it may not be enacted 4 to 5 years from now, given the fact that many SWOG sites represent, are part of the transplant committee, but also many of the community SWOG sites are recipients of our patients that we transplant, that this could potentially be a great opportunity to involve the SWOG program, and also the potentially not just the leukemia committee who could sponsor, but also the SWOG survivorship committee. I think that's the last slide there, other than saying that we know BOS is a disaster for our patients when they get it, and this would be the first preemptive study for BOS, and one of the first preemptive studies for chronic GVHD.
Okay, so where does this stand?
Well, at the moment, it's ranked within the BMT-CTN. The BMT-CTN are collecting all the proposals from the state of the science, including the CAR T lymphoma study you just presented. The next grant cycle for which funding will emerge is probably with the earliest study would be 24 months from now within BMT-CTN. So what we are actually talking about is this is a randomized phase 3, is to set up with one of the industry partners that we've started to dialogue with. Could we organize a multi-center phase 2, identifying patients who follow with spirometry? We find early evidence of VOSOP where we actually do a multi-center non-randomized phase 2 for proof of concept. So that also is a negotiation that's taking place currently.
Okay. Well, I can't get back my main screen. There he is. Thank you. Thank you, Richard. We do have time for a few questions. do you intend to capture data on any potential lung biopsies taken to assess the extent of lung fibrosis inflammation before and after treatment?
Good question. I think for most people now, for bronchiolitis obliterans, at least in the post-transplant setting, it's a diagnosis of based on clinical scenario and PFTs. There has been a decreasing interest in performing lung biopsies. Certainly, if that is collected, that would be of value, but more and more centers are using the pulmonary function studies as well as inspiratory, expiratory CT scan to make the diagnosis.
Okay, so this might be also a consideration for the CTP, the Clinical Trial Partnership, that's being run by Dr. Albane, which is kind of like the Alliance Foundation or what have you. So not necessarily just directly through SWOG, especially if the pharmaceutical partner is willing to support all these ancillary studies. So we should move this down the line and see if we can't get traction both in SWOG and through the CTP.
Thanks.
So thanks to everybody. We have a few minutes left. If somebody wants to ask a chat question, I appreciate everybody participating, and we have some interesting trials that are coming up, both in myeloma and lymphoma. And the last item that I mentioned was that this CTEP with SWOG, ECOG, and the Alliance are finally coming up with a MyeloMatch transplant group. There's a meeting coming up, I think within the next 3 or 4 weeks, with CTEP to kind of initialize this new committee. This also, I think, came out of the SSOS, in which a basket trial of maintenance, transplant maintenance therapies was considered to be one of the leading trials that need to be done in the next 5 years. So again, hopefully there will be opportunities for especially junior investigators to participate. So stay tuned for that. Once we have a little bit of information on that, we'll come back to all of you and hopefully involve some of the junior transplant investigators that are in SWOG. I think that's about it. I can't believe we started a little bit late. Everybody raced through it and got done with a couple minutes early. So thank you all for your participation, especially the speakers. And again, feel free if you have a question that wasn't answered or you want to have a protocol issue, contact the people that gave the presentations directly, or you can direct the questions through me at my email address. It's pstiff@lumc.edu, and I will forward them on to the appropriate personnel. Okay, thank you, everybody. Have a nice rest of the meeting. Goodbye.